Now we know that a lot of activity is on, particularly on this molecule, and a lot of meetings are also there, a lot of representations are there. So we'll have to see where we are placing this in a patient or in various sets of patients, in combination or alone. And we'll be happy to tell you on this. And as the questions come, probably we will open it to all of us, and then we expect your contribution towards a meaningful understanding and use of this molecule in our set of population. Great.
Respected professors and senior consultants and dear friends, it's really great pleasure for me to be here. And thank you, team Lupin, for giving an opportunity to be here. And so, no problem. And since we are in one of the very interesting area, the role of semaglutide for MASH as well as MASD, what are the major indications, to whom we are going to choose as a major thing we are going to address. Basically, we should know something about, because right now in global as well as in Indian scenario, MACD has been taken a clear-cut preponderance role to look for all the major changes rather than more than alcoholic liver disease. Almost 40 to 50% of the problem patients will be landing up with this kind of evidence. So rather than alcohol, now MACD along with westernized, in par with westernized groups, we have been landing up with this kind of presentation. As we all know, the common thing will be your fatty liver. Once a patient is going to land with evidence of fatty liver, the patient will be progressing to a condition what's called as non-hepatic metabolic associated steatotic hepatitis. If the patient is having hepatocyte degeneration, ballooning inflammatory cascade, it is going to get taken off. And next to that, the patient will be landing with evidence of fibrotic changes and cirrhosis. And if you're not going to control, there is high possibility for the patient to land with evidence of hepatocellular cancer. This is all well known. But in global scenario, as of now, every 1 in 4 patients, they have been landing with evidence of MACD. That's characteristic. And what we are supposed to know here, the major pointer is the nomenclature change we need to address. New list of molecules are there in the armamentarium guide for this MACD, but which is the best kind of molecule is still a challenging task for us to choose. And in case if you're going to use a molecule, whether you're going to use a combination therapy or monotherapy, and once the patient is going to subject to the treatment, we are not very sure if the patient is going to have a significant response. How are you going to titrate? How are you going to follow up the patient? Whether the patient is adhering to the treatment or not? Fine. If the patient is going to land up with evidence of cirrhotic background, whether the background of compensated or decompensated, what is the best kind of treatment? We are not waiting for still. And if the patient has fibrosis, in Indian scenario, is it easy to categorize? Because we have been focusing on urban population as well as in rural population. How are you going to recognize these fibrotic parameters in any way? How are you going to look for this? All these various indices, pointers, and all the biomarkers being tried. See, so many things regarding this. There's still major areas to get explored for this. We need to think about alcohol, very simple etiological assessment, pathophysiological factors we can guess. But to think about steatotic hepatopenia, metabolic associated steatotic liver disease, in which there is one more entity, what is called as MET-ALD, as we are well aware about that, in which if the patient is going to take alcohol, for example, around 400 grams per week, or in women background, if it is around 300 grams per week, if the patient is going to take alcohol along with evidence of these metabolic derangements, then we will be categorizing the patient as MET-ALD. But once the patient is having evidence of MACD, as per your IDF criteria, 5 major things. That's very important. Your dyslipidemia, your obesity, hypertension, along with if the patient is having dysglycemia. This is the major pointers, your waist circumference. All these pointers we need to take into account to look for that. What is the major hit? The briefly about the pathophysiology is still more and more exploring area. five major things. One is your insulin resistance. Once the patient is going to undergo insulin resistance, automatically the lipid accumulation pathway is going to get activated. The de novo lipogenesis is going to get activated, followed by the patient will have more lipid accumulation. That's the area increased PGA and all the various genetic manipulation will be taking on. That's mainly by your lipid pathway activation. It's number one pathophysiology. And number two, once if the oxidative stress if it is going to get based upon your mitochondrial oxidative pathway or reactive oxygen species, if it is going to get accumulated, that way the patient will be diagnosed with evidence of worsening changes for your MASLD, or if the inflammatory path, for example, your gut dysbiosis. This is very interesting and it's the most important exploring area. What is there to talk about that gut dysbiosis? See, there are two major entities which being involved. One is this Akkermansia species, that's very characteristic. And another one is Faecalibacterium plasmidii. That's also very good. If these levels will be having gut problem, if these things, that dysbiosis, if it is going to get augmented, if the eubiosis, if it is not going to maintain with this kind of bacteria, there is high possibility for the patient to have more of TLF, tolerant receptor activation, glycopolysaccharide accumulation, followed by the patient will have more gut inflammatory leakage pathways will be activated. That the gut dysbiosis is going to take on. That apart from that, your endoplasmic reticulum stress, right, with unfolding protein response, all the various cascades like your ATPase, all those enzymes it is going to get activated. That's the reason for this unfolding protein response. And apart from that, the lipid toxicity, for example, your diacylglycerol, your ceramides, all these things, if it is going to get accumulated, where the lipid toxicity is going to get happen. This is all the various impacts. And very importantly, adipokines, if it is not going to maintain in a proper way. If the adipokines, if it is going to go down, or if the leptin, if it is going to be augmented, that's the area if the patient is going to increase lipid peroxidation. And all the various enzymes like your beta oxidation failures, NADPH oxidase activation, all these things will be predisposing the patient for further oxidative damage. That's why thereby the patient will be landing with multiple events. That is all the various cascades is going to get taken on. That's all. So once this oxidative LDL is going to get happen, thereby the patient will be having cardiovascular. See, the most important mortality, as well the MASLD, the most common mortality is mainly because of the cardiovascular. Because around 30 to 40% of the population will be having cardiovascular mortality rather than per se diabetic or cirrhotic population. So how are you going to address? So very importantly, type 2 diabetes, the common predisposing event. 60 to 70% of the MASLD population will be having type 2 diabetes. 20 to 30 to 40% still be having evidence of hypertension. So your diabetes will worsen your MASLD. Your MASLD will worsen your diabetes. So all these things will be having coexisting interlinked pathway. That's how should not forget. We need to address each and every parameter. That's the area we'll be lacking, we'll be having difficulty. Which is the best kind of molecule we are going to choose, how we are going to address. It's still a challenging task when you are going to use. So, and very importantly, for example, this we should not forget. Once the patient is going to land with evidence of fibrosis, that doesn't mean the patient is going to land with evidence of hepatocellular cancer risk around 4 to 5% of the population. But now, increasing papers, what we mentioned is that even if the patient not having fibrosis, not having cirrhosis, in the background of MASLD, there is around 20 to 40% of the population. If the patient is having evidence of MASLD, there is a risk for the patient to progress for HCC. Even in the background, in the background of females. So this MET-ALD patient, are we going to use semaglutide? There are some papers. Why? In case if you are going to use that alcohol-induced craving effects will be having significant response with your semaglutide. That's what they've been proven. Because when you're going to use semaglutide, that alcohol craving will get controlled because the attenuation of nucleus activity, there are two areas they're going to address. One is in CNS, the pathway what is called as nucleus accumbens, apart from the ventricular medulla. These two areas will be having an attenuation response when you're going to use this semaglutide. So that's all the craving effect of alcohol also will get impaired when you're going to use this semaglutide. That is very interesting reasoning when you're looking into the data we came across. So semaglutide we can consider even for MET-ALD background to some extent, but at a reduced dosage level. That's what they'll be mentioning. At a low almost around 1 milligrams they'll be titrating, so they'll be having a response as what we are comparing with your when the background of only isolated MASLD alone. So in the background of alcohol-induced MET-ALD, we can still use semaglutide when you're going to have a significant response of therapy to be adverse. And between met ALD and MASLD in real world clinical practice, we still more challenge because we are not taking proper. There are usually various questionnaires out there. One is audit questionnaire, that audits the alcohol use disorder identification, and your craft mnemonic and all. There are so many things out there when you're going to use this alcohol screening guidelines, but that is a separate entity. Are we spending much of time? How do you going to analyze all these things? Are we taking the proper data? Whether the patient is consuming hard liquor, or whether the patient is going for beer, or whether the patient is going for toddy, what are the things? We are not very sure about the dose and all those things, but still they're challenging task. If you're suspecting met ALD, whether we can use semaglutide means definitely yes. And in which area in MACD do you think evidence generation is required? One is lean NASH. That's very important because still we are not having proper data. And apart from that, in which areas in MACD, evidence generation more needed means?
Generation.
We need to look for more and more data to get support because there are evidence, fibrotic reflection. That is very important because we are having trials to look for evidence of F2, F3. We have been proven, but over a period of time, around 240 to 250 weeks of therapy, when you are going to use, how far the fibrosis is going to regress, we are not very sure. And we need to generate more and more evidence of fibrotic regression because that is the area we need to target. And still we are challenging with this kind of things, and mainly for lean NAP, for the patient to prevent sarcopenia and other complications. How are you going to target that the clinical experience when you're going to use that? Still a challenging task. So these are all the areas we need to explore more and more. And elderly population, chronic kidney population, multiple other comorbids. This is all the things we should not forget in the cardiovascular risk factors. We need more papers to support that.
We didn't address one important factor, intestinal microbiota. Role of intestinal microbiota in MASH.
That itself has been taken as a separate
microbiota metabolite, that is triple N 5-aminovaleric acid is increased in patients suffering from MASH. Trimethyl 5-aminovaleric acid. We should calculate about the financial.
At that time, only one drug was there, sir. Now only like all the semaglutide, like generic.
So I prescribe resmetirom for many patients. Now it's not available in the market.
The answer that I can give you is like surgeons have many methods of doing the surgery, but they do only one method, and they will be an expert in that. Because majority of the time you don't need to know all the methods, and you don't need to do all the methods. So gain your experience of particular patients, and hold it on. If someone is not able to afford, it's better to hold it back. And then pay for some time quickly. It's not going to help your problem. It's not a build up your experience of particular patients or occupations. Then you be an expert at one issue. Then go for combination. This time it's better to hold back because I think
PAR pan-agonist, in which the problem is there are some patients will be landing with evidence of peripheral edema when you're going to use it. That is why the cardiovascular is still they're not having much recommendations for this PPAR agonist and all when you're going to use. Peripheral edema, risk factors, cardiovascular fluid overload. These are all the things still challenging when you're going to use. So do that kind of patients.
With semaglutide.
No. PPAR agonist. So these are all the newer things. Yes. In the pan PPAR, as we are coming across it is only delta, but here is pan PPAR, which means alpha, your delta, as well as your gamma. There are three major mechanisms. One is by beta oxidation pathway, the other one is insulin sensitization. The middle one will be because of your mitochondrial lipogenesis, mitochondrial pathways. These three areas to get addressed when you are going to use your pan PPAR. So that is why we need to consider that. And still, cardiologists having a questionable role to use that. But we can able to consider along with that. Nowadays, combination therapy, resmetirom with semaglutide, resmetirom with lanifibranor, resmetirom with your lanifibranor with semaglutide. There are combination trials are still happening, and there are three molecules being tried: your semaglutide, lanifibranor, along with the resmetirom.
You can combine dapagliflozin also, no?
Yes, sir.
Sodium glucose co-transporter. That's also got an effect over this MASH.
Yes, sir. So this is what there have been various trials that you mentioned, safety analysis and all those things, nothing much here. And adverse events, I think we have been already discussed your nausea and GI symptoms. And what real world challenges regarding tolerability, adherence, the patients will be going to face. And and next to the lean NASH trials. So, do you want to take over this question? What real world challenges we are going to face on adherence to the therapy?
Anyone from hospital?
Sir, yes.
Yes, there. I think you have been so much interested in obesity and a lot of surgeries also, and probably your team is one that has started all this drugs very early practice. Probably you are we have a 5-6 year data.
No, sir. From medical gastroenterology, we have started 1 month back. So we have done on ESG endoscopic sleep gastroplasty. That bariatric field of surgeon sides. From gastro side, we have started just 1 month back. We have started.
Praveen has been using it now for a long time.
No, he is from surgical side. We own from Coimbatore they have.
See, bariatric surgery, as per the guidelines, what I mentioned, the BMI if it is tends to be more than 40. And apart from that, once you are going to use a bariatric, even nowadays for 35 BMI, there are some complications still, but there are some papers to look for that evidence of your fibrotic regression as well as evidence of your steatosis regression. Your MASH improvement will be almost around 50 to 60% of the population will be having significant response with the bariatric therapy.
Now this is a question on tolerability and adherence. So, what has been your experience on this? Pretty much. Let us try to understand what others are saying.
Sure.
Actually, we have started 2 patients in Semaglutide. So far is fine. Actually, we have combination with ESG plus Semaglutide. So we now, maybe the second month, till now no symptoms.
Anyone else to contribute?
I think apart from the GI complications, I think the anhedonia, like the loss of interest in the normal things that usually cause them happiness earlier, that is somewhat unmet. Like we've not really addressed that. Suicidal tendencies, yes, it's a contraindication, but they stop enjoying even the simple things after a long point in time. They also reduction in cravings, that's like a positive way to look at it. But the normal things, the music or the good food, what they were enjoying, that also they stop. So I think that has to be addressed in some way, like some counseling or something like that.
Anyone else from their personal experience?
Loss of muscle mass.
Loss of
muscle.
That's why most of the cardiologists they've been recommending nowadays with this semaglutide. Every cardiologist
There is a cardiovascular and the atherosclerotic cardiovascular risk reduction is better. It's semaglutide for diabetic as well as for non-diabetic patients. Whereas tirzepatide is better only for diabetic patients, for not non-diabetic patients. And also, it's we got what is called as a congestive cardiac failure. That score points also increased by the semaglutide. That is, the ejection fraction maintained.
That the patient is going to respond normally. If the patient no fibrosis, doesn't mean that the patient is not going to land at the evidence of cirrhosis or present cancer. So always the screening criteria, the methodology, all these things we need to address when you are going to tackle this. Now for the expert panel discussion, what percentage of your monthly patient population falls in the following categories? Patient with obesity who also have MASLD, patient with overweight also have MASLD, with normal weight who have MASLD. What is the age spectrum? So this question we can take it open for discussion. We can take it. Uma, do you want to take this question? See, in this question they have been asking obesity background overweight. So obesity, if the BMI tends to be more than 3.0, if the overweight in Indian scenario more than 2.5, in global scenario, in Indian scenario, if the overweight parameters of the BMI tends to be more than 2.3, so which means the patient. So obesity around 60 to 70% of the population, overweight around 10 to 40%, on normal weight still